to start us off, it's my great pleasure to introduce Dr. Pérez-Stable for opening remarks. He's the director of the National Institute on Minority Health and Health Disparities. Before joining NIMHD, he practiced general medicine, internal medicine for 37 years at the University of California, San Francisco, and he has been very supportive on these efforts on liver disease disparities research. Dr. Pérez-Stable.
Thank you, Rena, and thank you much, John, for leading the charge. I'm going to be brief, both in terms of welcoming and hopefully setting the stage. I was asked to, I can't get this, hang on. There we go. I'll get rid of that slideshow. Here we go. All right, so hopefully those are visible to everyone. And spend a few minutes reviewing some of the data and highlighting what I think are some of the issues, the big picture issues we need to hopefully focus on through our research. So I'll start with just a quick summary of how we see things at NIMHD. You know, how do we do science to reduce inequities? This applies across the board for all conditions. Hepatitis, liver disease are no exception. You know, standardized measures, big data science, big data capacity, discovery science is really important there. We need to have diverse workforce. That's a huge gap that we need to continue to push on. We need to continue to cultivate community engagement if we want change over time, and this requires building sustainable trusting relationships. And then we need to implement what we know, and we are falling short on that in many areas, including hepatitis prevention. Everyone, hopefully in this audience, knows our populations with health disparities are listed at the top 4 bullets. We embrace the idea that all of these populations share this common theme of having a social disadvantage resulting from being subject to discrimination or racism and being underserved in healthcare. And then a health outcome that is worse is what we call a disparity in some comparison group or some metric of standard ideal health. There are many, many reasons why measuring race and ethnicity and socioeconomic status as really parallel pillars in the science that we fund and foster are important to measure in everything that we do with humans, because there's so many things that they matter and that we don't understand why. That we should measure and consider before we discard them as explanatory associations or factors. Predict life expectancy, mortality. We see more strokes in African Americans compared to whites in an observational cohort study for the exact same level of systolic blood pressure. There's more chronic disease in people who are poor, and many of these are related to structural factors. And then even within a diagnosis such as diabetes, we see differential outcomes related to heart disease and end-stage renal disease, influenced by your self-identified race, ethnicity. Again, direct the audience to our research framework developed by staff a number of years ago to capture this complex dimensions, levels of influence, and domains of influence that affect us. Most of the research we still fund is here in this first column, individual. We do think a lot about community and societal, but the funding trails down as we go from left to right. And if you ask me about a causal direction of disparities, it's probably more in the right to left direction than the other way. So this is just as background. So what do I think are the most important things in hepatitis, chronic liver disease, and liver cancer? And these are not different from last year, I think, for the most part. So, you know, first and foremost, hepatitis B is preventable with a very effective vaccine that we've had now for, I think, I'm going to lose count here, but probably around 40 years. If you look at the experience in Taiwan, they have had a big impact on the rates of liver cancer because they implemented and successfully implemented hepatitis B vaccine broadly. The US picked up in the early 90s with universal vaccination, but as you will see, we're far behind in getting universal acceptance or uptake. And we've been there with COVID, so we know that this is an issue. Hepatitis C is curable for the most part, not entirely, but most of the phenotypes seen in the United States can be treated with a regimen of 8 to 12 weeks and get 90–95% cure. So this is something that wasn't even dreamed of 10–15 years ago. And now we've seen already an impact on liver transplants related to hepatitis C going down. So again, we have the tools, it's implementation that is needed. There's a lot of evidence that causal pathway to liver cancer and chronic liver disease includes inflammatory conditions, and fatty inflammation being one of the main ones leading to chronic liver disease and cirrhosis. Of course, hepatitis B and C can do this even in a quiescent way. And then aflatoxins are also potentially having a role, particularly on the border in the Mexican-American Latino population. Liver cancer is increasing predominantly only in American Indian, Alaska Native populations. But as you will see, it is, well, I don't think I show the data, it is much more common in men than in women. It is much more common in all of the racial and ethnic groups across the US compared to whites, the minority groups. And we're seeing that this proportionate effect, there's different etiologies. So hepatitis B has been the predominant cause among Asian Americans and Pacific Islanders. It is not the predominant etiology among Latinos, but hepatitis C may be more of a role in African Americans and so forth. So I think this needs data on local and regional data is going to be important, and then targeted screening and early treatment of the small population of women who are pregnant who have chronic hepatitis B, predominantly immigrants from Africa and other high prevalence, low income and middle income countries, not Latin America necessarily, but mostly East Asia and Africa and sub-Saharan Africa. We can control this if we identify, treat appropriately, and immunize the family. Quickly show some data. This is thank you for the NIMHD staff that pulled these slides together, and in Rena's division. We see this rate of hepatitis B prevalence predominantly seen in this Asian/Pacific Islander group. And in this case, the effects of the condition are in the similar direction. We've made progress here, which we haven't in the other groups, more in African Americans as well. And again, we see the male more likely and the urban population more likely. Vaccination uptake is pretty bad. If you look at it, any way you look at this, oh yeah, the Latinos are the worst at 27%, but the best group, even if it's 40%, we're still looking at a very low level of immunity. And when we started out with Hep B, it was like all these risk groups and targets and stuff, and that probably confused the community more than anything. Universal vaccination in children, in newborns is important, and if not, immunizing adolescents pre-adolescence, so at the 9, 10, 11-year-old group. But we really have to make this a much bigger emphasis. It's a safe, effective vaccine that probably has, I don't want to say lifetime immunity, but very, very close to that. There are rarely any reported cases of someone developing acute hepatitis B after they've had the full range of hepatitis B vaccination and had a good antibody response. In terms of hepatitis C prevalence, we have a better handle on the epidemiology of this, and what stands out from the data available from the CDC here is the American Indian Alaska Native population just really at much higher risk. Again, a male predominance here because of the American Indian. In part, you see more of a rural predominance. Transmission is not always so clear. Probably similar to B, although the level of infectivity may not be at the same level. And then you don't see, let's say, the Hispanic population, which I'm more familiar with, Latinos, based on the SOUL study, Puerto Ricans had a higher rate of hepatitis C exposure, but not the Mexicans and not the Cubans or Dominicans or South Americans who were in that cohort study. So you do see differential epidemiology here across the board, but it stands out again, American Indians, Alaska Natives, disproportionately affected. And overall liver disease, again, overall rates are low. You see high rates, the highest rates for Mexican or Mexican Americans. But again, the absolute rates are low. And it is primarily an effect of the multiple components contributing to chronic liver disease. Again, fatty liver inflammation consequences, not fat itself may not do it, but just the inflammation that follows. This is chronic liver disease mortality. American Indian, Alaska Natives up here. And then you see the other groups with the Latinos being second, and whites next. And then you see some other groups sort of clustered down here at the bottom, with an increase now in Native Hawaiians. We're finally getting some data clear cut across the board on Native Hawaiian Pacific Islanders separate from Asians. And it's so critical to do that given the fact that their outcomes are different in many conditions. CDC has, this has been a standard from the CDC, National Center for Health Statistics, since the year 2000. It just took all these years for the states to come along and start reporting it differently. So we always blame the federal agency, but it really was the states that dragged their feet on this, especially for the death certificate categories. And liver cancer, again, not separated by sex, which if we would, we'd see it's 3 times more common in men. And again, see this increase in American Indian, Alaska Native. It's the only group where we're seeing it go up. It has sort of flattened or started to come down among Latino Hispanics and has generally come down for Asian Pacific Islanders. I'd like to think this is an effect of hepatitis B vaccination uptake, since this population was targeted initially more, given the immigrant population coming from high prevalence countries. And again, we could do a lot more here if we implemented vaccine and treated hepatitis C. I mean, it wouldn't eradicate it, but it would certainly get a handle on it. And liver cancer is now, it's either 5th cause of liver cancer mortality, of cancer mortality among men, and it's right not far behind for women. And these are the mortality data that parallel the incidence data that I showed you. NIMHD and NCI did have a funding opportunity announcement in this topic. In 2017, we received about 100 applications. 12 grants were funded, so that's about average for our ICs in terms of awards success rate. Some of the sample topics are listed here. Mechanisms of, let's say, non-alcoholic fatty liver disease, community approach to improve hepatitis B screening in a targeted population of West Africans, and looking at multi-level factors for hepatocellular cancer. We continue this, and so we welcome these applications, and I think NIAAA was also signed on to this, but none of the applications signed to them were funded. So thank you for your attention, and love to hear what we came here for, the scientific seminar.